Great, thank you very much. Thank you to Pete and the organizers for the invitation. It's a great honor, and thank you for being such gracious hosts in the city of Edinburgh. So I've been tasked with talking about novel combinations in MRD, and in particular, I think it's great that John and Susan set this problem up so nicely. These are my disclosures. And alluding to the analysis by Jake Sumerai and colleagues recently that John Seymour just mentioned, nearly 2,500 patients were examined in this model. And it was determined that patients on novel agent monotherapies with high risk factors, several clinical factors, in addition to the usual genomic factors, may have short survival. And this applies across the different novel agents as seen here. So this really defines the problem where perhaps novel combinations may help improve survival, particularly for these high risk patients. So in my talk, I'll initially discuss relapsed refractory CLL progressors and give a couple of different examples of novel combination approaches. We'll also discuss Richter's syndrome, which unfortunately remains a major problem for our CLL patients who are progressing on novel agents. And then at the end, I'll touch on future combination approaches to target other members of the BCL2 family besides BCL2 itself. So let's start with relapsed refractory CLL progressors. We heard from Susan about the PI3 kinase inhibitors that are now approved, which can be efficacious, generally have more manageable toxicity profiles in the relapse setting compared to the frontline setting, but unfortunately are not particularly durable in terms of monotherapy approaches. So one idea might be to do dual blockade of the B-cell receptor pathway. We've seen many times this pathway, which has multiple arms, including one depending on BTK and one depending on PI3K. And perhaps by dual blockade of the B-cell receptor pathway, we could prolong responses and overcome mutations such as BTK C481S. So an early attempt to do this by Paul Barr and colleagues looked at inhibition of SYK and PI3 kinase delta with idelalisib. Unfortunately and unexpectedly, this led to significant toxicities, including pneumonitis, which was quite severe in several patients. So I think it can be challenging to do blockade of this pathway in two places because of toxicity. We took a different approach, which was to target BTK, and instead of using idelalisib, to use umbralisib to target PI3K. As you just heard from Susan, umbralisib has a favorable safety profile, and so far seems to have lower rates of immune-mediated toxicities compared to the other PI3 kinase inhibitors, with good efficacy in relapsed refractory CLL patients. We recently published our study combining umbralisib with ibrutinib as a continuous therapy approach for patients with both relapsed CLL and mantle cell lymphoma. We treated patients starting at a dose of 400 milligrams of umbralisib, and in the phase 1 portion escalated up to 800 milligrams of umbralisib with good tolerability. If you focus on the grade 3-4 toxicities here, you see very low rates of immune-mediated toxicities, in particular diarrhea, transaminitis, and no pneumonitis here. And so this did seem to be a feasible approach. We were able to identify 800 milligrams of umbralisib as a recommended dose to move forward. And this did lead to a high rate of complete remission. Nearly 30% of patients in our study with CLL achieved complete remission, which is higher than we might expect in a heavily pretreated relapse population, for example, with ibrutinib monotherapy alone. And you can see across the different dose levels, these were deep responses on this waterfall plot. So far, this has translated into promising 2-year progression-free and overall survival, although the follow-up remains short on our study. Of course, there's a lot of interest in targeting the two Achilles heels of CLL pathophysiology, as we've heard earlier in this meeting, and we'll hear later today about the clinical results of targeting BCL2 and the B-cell receptor pathway simultaneously. We had previously shown, using a technique that I'll talk more about at the end called BH3 profiling, that CLL cells treated ex vivo with BTK inhibitors actually have enhanced dependence on BCL2 for survival. And this effect was true both with ibrutinib and acalabrutinib, suggesting that this is a direct effect of BTK inhibition itself. And by giving this combination ex vivo, we were able to achieve synergistic killing of primary CLL cells. This has now led to the development of multiple clinical trials, which are very promising. You'll hear later in this session more details about the UK Clarity study, so I won't go into detail here, but certainly just to mention that the rates of undetectable MRD, both in the blood as well as in the marrow, look very promising. And to me, one of the highlights of the ASH meeting this year was these progression-free and overall survival curves from Clarity, which really look like frontline curves for CLL patients. But you have to remember, this is a refractory population, and so this is particularly impressive durability, although of course we do need longer follow-up still. I'll remind you also that the MD Anderson has been doing a study of ibrutinib and venetoclax in the relapsed refractory setting. This has been running in parallel to their frontline study that was recently published in the New England Journal. These data have not been updated for a couple of years. In this initial presentation of just 34 patients, they had already seen promising data for rates of MRD undetectability. and I expect that we'll see updated data for the full 80-patient relapsed refractory cohort presented soon. So if targeting 2 aspects of CLL pathophysiology is effective, what about targeting 3? Might this result in even greater efficacy? So we've been talking about BTK and BCL2. What about adding a CD20 monoclonal antibody? So we have some initial data for the 3-drug combination of ibrutinib, venetoclax, and obinutuzumab from the Ohio State group, and this appears to be well tolerated and active in this very early data set. We certainly see several cases of MRD undetectable disease in both the blood and the marrow. But these data sets remain early, and I think it's unclear at this point how much activity the obinutuzumab is adding. And certainly future studies will need to define the importance of the CD20 in this combination approach. So switching gears a little bit, still targeting the B-cell receptor pathway in combination with BCL2, but now using PI3 kinase inhibitors. And we had done some very early work several years ago showing that in a stromal culture model, we see resistance to BCL2 inhibition, and this can be partially overcome by treating with a delta isoform PI3 kinase inhibitor. We showed using the BH3 profiling assay that this may be due to also an increasing dependence on BCL2 when these cells are treated with PI3 kinase inhibition. Others, such as Varsha Gandhi and her group at MD Anderson, have shown that in patients treated with the delta gamma inhibitor duvelisib, the venetoclax appears to be a particularly promising partner in terms of a combination strategy. Further rationale for developing a BCL2 PI3 kinase combination is that both venetoclax and PI3 kinase inhibitors are efficacious as single agents, as you've seen, but they tend to have low CR rates and, at least when given as monotherapy, require indefinite treatment. We know that we have many older CLL patients who have cardiac comorbidities and may not tolerate BTK inhibitor therapy as well. And venetoclax and PI3 kinase inhibitors in general have non-overlapping toxicity profiles, although in theory there was the potential for drug-drug interaction. So we recently launched a phase 1/2 investigator-initiated study of duvelisib and venetoclax for relapsed refractory CLL patients. In the phase 1 portion, we were cautiously starting at 10 milligrams of venetoclax, given potential risk for drug-drug interaction and tumor lysis syndrome, with escalation up to 100 milligrams in the first dosing cohort, and then up to 400 milligrams by week 6 in the third dosing cohort, with a plan to then move into a phase 2 expansion portion. This study is designed as a 1-year time-limited therapy, and patients who are undetectable for MRD can cease therapy and go on to observation with retreatment if they exhibit progression. And we hope to be able to report the results of this study soon. A similar approach is also being taken with umbralisib. Paul Barr and colleagues had developed a phase 1 experience using umbralisib and venetoclax in combination with the CD20 antibody ublituximab. And Rick Furman is now leading a phase 2 study of the so-called U2 regimen with venetoclax for relapsed refractory and now frontline CLL patients as well. This will be a large study of 150 patients who will be treated for 2 years with the potential to come off therapy if they achieve MRD undetectability. Let's switch gears to Richter's syndrome because this remains a major issue for our CLL patients, and I'll discuss 2 major strategies, including novel agent plus chemoimmunotherapy, as well as novel combinations with checkpoint blockade. We know that Richter's syndrome has poor survival after chemoimmunotherapy. In this older series, there was a median survival of only 8 months in these patients who developed Richter's after chemoimmunotherapy. In a large multi-center collaboration of a retrospective study, we looked and found 70 patients who had progressed with Richter's syndrome after novel agent-based therapies for CLL. And you can see in this group, the survival was particularly short at only about 3 months. Anthracycline-containing chemoimmunotherapy is still used commonly, but the outcomes remain poor for most patients. So we do urgently need novel therapeutic strategies. So this is data from the Ohio State looking at our EPOCH chemoimmunotherapy with a complete response rate of about 20%. We had also seen in the venetoclax phase 1 study that 7 patients with Richter syndrome were treated with venetoclax as a monotherapy, and 3 patients achieved response, which actually in all cases had some durability greater than 1 year. So we hypothesized that by adding venetoclax to our EPOCH that we could chemosensitize and allow these cells to have a greater cell kill, which potentially could translate to better outcomes. This is sort of the concept here. We're using venetoclax as a rocket booster to try to bring these cells closer to apoptosis and really use a chemosensitization approach. This is the study design. We start with a cycle of our EPOCH chemotherapy, and then when patients recover their counts, we introduce venetoclax dose ramp up. Because these patients often have very aggressive disease with Richter's, we are exploring an accelerated daily venetoclax ramp up, where each day patients can ramp up to the higher dose, getting to 400 milligrams by day 5. At which point they can then move on to combination therapy with venetoclax 400 milligrams in combination with dose-adjusted R-EPOCH. We give venetoclax only on days 1 through 10 to minimize the risks in the nadir period. And patients can get up to 6 cycles of this combination. This is a multi-center study that we're conducting with MD Anderson and Ohio State, and we presented the data for the first time just recently at the Lugano meeting. We've treated 26 patients to date. These are relatively young patients, median age of 63. You can see they have high-risk disease characteristics, median of 2 prior CLL therapies, and most of the patients had had prior chemoimmunotherapy, with several of the patients also having novel agent-based therapy for their CLL in the past. There was a fair amount of hematologic toxicity, as you might expect, with the chemoimmunotherapy regimen. There was also a significant rate of febrile neutropenia of about 20%, with some significant infections. So these patients need to be managed carefully to make it through. But I think one thing that was striking was that there was no tumor lysis syndrome observed with daily venetoclax ramp-up after 1 cycle of our EPOC for cytoreduction. And this was in 20 patients who completed this ramp-up. 18 patients at this point have started the combination therapy and are evaluable, and the complete remission rate is 67%. Certainly compares favorably to the rates of 20% that we might expect from chemoimmunotherapy on its own. And all the patients who achieved CR for their Richters also had undetectable bone marrow MRD for their CLL. Several of these patients have now moved on to allotransplant, and some of the patients are now approaching 2 years post-allotransplant and remain in complete remission. These are the survival curves, uncensored on the left and then censored at time of allotransplant. The median follow-up remains short at 3 months, but the median overall survival is promising right now at 16 months. What about checkpoint inhibition in Richter syndrome? Certainly there was a lot of excitement with the initial data from the Mayo Clinic looking at pembrolizumab, where some very nice responses were observed. But more recent series have not necessarily confirmed that. We have seen activity of combinations, though. Nivolumab plus ibrutinib was recently explored in a larger phase 1 experience, and in the subgroup of Richter's patients, there was a 65% overall response rate, as recently reported by Anas Yunus. So another interesting study being undertaken at MD Anderson right now by Jane and colleagues is the combination of nivolumab PD-1 blockade with ibrutinib. These patients are given a dose of nivolumab and then combination therapy with nivolumab and ibrutinib ongoing. Another young age group of median age of 64. Most patients were heavily pretreated, including with novel agent-based therapies. And you see here about half of patients had TP53 aberrant disease. This is the toxicity profile of the nivo ibrutinib. You do see some of the usual toxicities you might expect from ibrutinib, as well as some immune-related events that are probably more likely due to the nivolumab, including some pneumonitis and transaminitis. But in most cases, these toxicities were manageable. They've seen 42% of patients respond, including 8 complete metabolic responses, and these did include patients with prior BTK inhibitor exposure. They've also been able to bridge patients to allotransplant, and the median overall survival at this point is around 14 months. I'll highlight also one other study combining umbralisib and ublituximab, the U2 regimen I mentioned before, this time with pembrolizumab. And this is for patients both with relapsed refractory CLL or with Richter syndrome in 2 different cohorts. You see here in the CLL cohort, they start with the U2 doublet, and pembrolizumab is introduced during cycle 3, with continuous umbralisib given thereafter. In the Richter's cohort, all 3 drugs are started early to try to establish disease control, and there's a maintenance portion of the 2 drugs, ublituximab and umbralisib. These data were also recently reported by Anthony Mato at the Lugano meeting. They've treated 20 patients at this point and have seen 1 DLT at 200 milligrams, which was a transient elevation in LFTs. In total, about 20% of patients had grade 3 or higher LFT elevations, but there was no grade 3 or higher diarrhea or other pembro-associated autoimmune events. And so this does look like it's going to be a tolerable combination. I'd say the preliminary efficacy data look promising, and this is a waterfall plot looking after the initial induction in CLL patients with U2, followed in blue by the pembro consolidation. So there does seem to be some deepening of response by adding the PD-1 blocking antibody. And I think in particular, it's important to highlight that 6 of these patients who were refractory to BTK inhibitor were treated, and 5 of the 6 responded. These are the data in Richter syndrome, a small number of patients here, but we do see 3 patients who have achieved response and a couple more who have had clinical disease benefit. And again, these are heavily pretreated Richter's patients. 7 of the 8 were refractory to BTK inhibitors. So certainly promising data. So in the last few minutes, I'm going to turn to future combination approaches. This is probably the more speculative part of the talk, but I'll kind of give you my perspectives on where we might be headed with targeting the BCL2 family. So you saw yesterday from Marianne Anderson that this is a complex family of BCL2 family members. And I'll highlight over here the anti-apoptotic proteins. We talk a lot about BCL2 targeting with venetoclax, but BCL-XL and MCL1, BCLW and BFL1, they all represent potential targets for this disease. So a little more detail about the BH3 profiling technique I mentioned earlier. This was developed by my mentor, Tony Latai at Dana-Farber. And this assesses the functional dependence of cells of interest on a specific anti-apoptotic protein. The way we do this assay is by obtaining a primary sample, in this case from CLL patients, plating them out, and then exposing them to specific BH3-only peptides that simulate the action of native BCL2 family members. We can then fix the cells and examine how much cytochrome C is released in response to each of these BH3-only peptides. And this gives us a sense for how dependent the cell is on a particular anti-apoptotic protein. We can do this through this heat interaction map. So for example, if we look at the NOXA peptide, that binds with high affinity to MCL1, so that will give us a sense for MCL1 dependence. HRK binds to BCL-XL only, so again, gives us a good sense for how dependent the cell is on BCL-XL. So in earlier work, I showed that there is a range of priming for apoptosis in CLL cells, but most CLL patients are very primed to undergo apoptosis. And the majority of CLL patients depend on BCL2 for survival, at least when we take cells from the peripheral blood. So in this series of the 30 patients, 22 had a primary BCL2 pattern, but there were some patients who depended more on MCL1 or BCL-XL, even in the peripheral blood-derived cells. This is a little bit of unpublished data, just an interesting case that we looked at of a patient who was on the initial study of venetoclax monotherapy for relapsed CLL and later developed progressive disease. This is some raw BH3 profiling data, and I'll direct you first here to show in the pretreatment sample in the blue, this patient was very BCL2 dependent, as you see here by the BAD and ABT199 depolarization. But at the time of relapse, this patient was far less sensitive at the level of the mitochondria to inhibition of BCL2. And in this same patient, we saw an increase in the MS1 NOXA peptides, suggesting that these cells were now functionally dependent on MCL1 for survival. You saw from Kathy Wu the recent work looking at MCL1 being increased as well at the protein level, as well as increases in dependence on OXPHOS and other transcriptional regulation. So I think, as Marianne elegantly described yesterday, there may be multiple mechanisms of resistance to BCL2 inhibition. And one other that I'd like to mention is the work of the Dutch group looking at the lymph nodes, because we know that lymph nodes are really a key microenvironment for CLL cells. And they've nicely shown that BCL-XL is expressed here in the red at higher levels in lymph node tissue compared to what we'd expect in the blood. And when they stimulate these CLL cells with CD40 to mimic a lymph node microenvironment, they see upregulation of multiple anti-apoptotic proteins, including MCL1, BCL-XL, and BCL-W. And this suggests important resistance mechanism for venetoclax. So we've had a drug in the past that targets BCL-XL. It also targets BCL2. This, of course, is navitoclax. This is just to remind you of the phase 1 data published by Andrew Roberts and colleagues, where navitoclax had good activity in CLL with these excellent responses in the waterfall plots, but unfortunately also had on-target thrombocytopenia likely due to BCL-XL inhibition. So I think a BCL-XL selective inhibitor actually could help overcome this issue because you could titrate the dose appropriately in a ratio to the BCL2 inhibitor to try to maximize efficacy while minimizing thrombocytopenia. And this is a tool compound published by the AbbVie group, certainly showing excellent activity at inhibiting BCL-XL, but we're yet to see a BCL-XL inhibitor in the clinic that we can explore. In contrast, there's now 3 promising direct MCL1 inhibitors that have recently entered into the clinic. Molecules from Servier, Amgen, and AstraZeneca are all now in early phase trials. And I won't show you data today, but we expect data to emerge soon. I think that these drugs may have some single agent activity in certain CLL patients, maybe the minority of patients that depend primarily on MCL1 initially. But I think perhaps where the role is greatest for these drugs may be in combination with BCL2 inhibitors, where I think there could be tremendous potential for combination efficacy. You don't necessarily need to directly inhibit MCL1. MCL1 is a very short half-life protein, and so anything that inhibits transcription can potentially decrease levels of MCL1 with a therapeutic window. And so CDK inhibitors are an example of that type of approach. One example of that is Verusiclib, which targets CDK9 and others. It's a transcriptional regulator of MCL1 that's orally bioavailable and has a favorable safety profile from solid tumor studies. So we're now running a phase 1 study of Verusiclib in B-cell malignancies with a goal to try to quickly get to a combination of Verusiclib with venetoclax, which we think could be very efficacious. So in terms of how I see this moving forward in the future, I think there's a number of different approaches that may help us to individualize our therapies to target the BCL2 family. BH3 profiling is one example of a functional study where we can assess the dependencies of a patient at baseline. Most CLL patients will likely depend on BCL2 and be good candidates for venetoclax. But some patients may occasionally be BCL-XL or MCL1 primarily dependent, and perhaps we could start with a different agent for those patients. Some patients may depend on more than one and may need combination therapy from the get-go. I think at time of progression or relapse, we may see changes in this pattern of dependencies. For example, this patient initially who was dependent only on BCL2 may now also be dependent on BCL-XL, and so adding a BCL-XL inhibitor may make sense for this type of patient. So to conclude, I would say there's several promising novel combinations now in development for CLL. We reviewed just a couple of examples, including dual BCR blockade, as well as combination of BCR pathway inhibitors plus BCL2 inhibition. Novel approaches for Richter syndrome include chemosensitization strategies, as well as checkpoint blockade, plus the B-cell receptor pathway inhibitors. And as I was just discussing, I think a promising future approach could be to combine agents that selectively target anti-apoptotic proteins. And this may be individualized using both functional and genomic-based assays. Thank you very much.